Thank you for this opportunity, for allowing me to share with you my version of how the brain receives, interprets, and then continues in a chronic pain cycle. My background is neurophysiology with a cranial orofacial dimension. So my expertise is in the brainstem and how it pans out based upon the sensory mapping, based off the cranial nerves, based on heart rate variability and CO2. So I basically do neuroengineering. My thesis in beginning the context of my viewpoint is that each one of us has a different sensory map based upon, of course, our experiences based upon perception, the input, and the proprioception. So I discover the sensory map through the cranial nerve exam. I have created it from a dynamic dimension to consider the override possibilities to hide information that's right there for all of us to discover. But if it's not done in a correct sequence, we miss that information. I totally support the concept that 40 to 80% of all diagnoses are incomplete. Incomplete means that there's information right there, but it's not available because we're not doing the proper evaluation to get that data. So when I start with a dynamic cranial functional exam, I don't ask a lot of questions because I'm finding out what the brainstem wants to tell me, not what the person wants to tell me. That's another dimension, of course, but it's not where I start. I start with the motor cortex, and the reason why I'm starting with the motor function is because I don't want the sensory information to be altered or activated, because I believe most sensory maps are not what they were originally designed to do, due to injury, due to trauma, and of course surgery. So, where do we start? I start with the bottom of the brainstem. For the simple reason is for retained compression. I believe that retained compression could be birth-oriented or injury-oriented. And when we have that tug on that brainstem, should the brainstem become removed slightly out of the housing of our skull, then we can have some incorrect signals, some compromised signals that can influence the whole brainstem. So I start with cranial nerve number 12. In order to have a functional, accurate information of cranial nerve number 12, one must have their eyes closed. Absolutely, if I want to know motor function, I have to remove sensory input. This will tell you a lot of information. I find most of the time we have asymmetrical tongue function when we stick it straight out with our eyes closed. I experience over 70% differences if the eyes were open versus if the eyes were closed. This is also going to let you know about fasciculations. Fasciculations is an electrical dimension. When we have fasciculations, we have a compromised cranial nerve number 12. We want to pay attention to this because if we have a compromised cranial nerve number 11, spinal accessory, and a compromised vagus nerve, and a compromised glossopharyngeal, then that's when I look at my colleagues to do an optimal diagnostic tool, a standing MRI. When we have a standing MRI, we can see, has there been some injury? If there is injury, it's going to show up, whether it's 1 millimeter, 2 millimeters, 2.5 millimeters. Where is the vulnerability of the brainstem due to biomechanics and injury? They will almost always give us some missed signals. Then we go into spinal accessory, my second nerve I test. Again, I perform the test when the eyes are closed. When the eyes are closed and we see an asymmetrical shoulder lift or significant asymmetrical lateralization of the head, we know that our 11th nerve is also compromised and we can have up to 4 positives. Then we can go to cranial nerve 10. If we're going to focus on the motor dimension, of course heart rate matters. Depending on your sophistication, you can do heart rate variability. That will give us more data as far as where is the motor component of the vagus nerve. Another motor component is the position of the uvula. In order to do that, the tongue must be in the mouth, eyes must be closed, and you simply have them open their mouth. They do need to motor the sound ah. When they do that, you will look and see if proper function of the uvula is present. That's wonderful. It will vibrate as well as elevate, and it will contract just like an accordion. So again, we have them close their eyes, retain the tongue inside the mouth, have them give us a very big, long ah as we view with, of course, a flashlight, what's going on inside there. Does it vibrate? Does it elevate? Does it contract? And most importantly, where is it located? If it is asymmetrical, we do know that there's a neurological component off the brainstem. Making note of that gives us more reasons to do a standing MRI if we have a positive of 12, positive 11, and a positive 10. So you can have many positives on this nerve from a motor dimension. Then we go back and check cranial nerve number 9. When you check the glossopharyngeal, the motor component would be the same thing. We would want them to close their eyes. We want them to open their mouth, keep the tongue inside the mouth, and then we would view taking the back end of a cotton tip applicator to see if they can say ah while we touch the back of the wall. We would not want to have a gag reflex. We would also want them to be able to bite on then the cotton tip applicator, and we would want them to swallow, again with the eyes closed. When you can swallow, what happens? The only thing that should happen is you should see function above and below the hyoid. When you swallow, the face shouldn't move, the lips shouldn't move, the shoulder should move. You should not have any accessory function to retain a swallow from inside the mouth. If they have, there are significant implications we'll go into next. So for the most accurate things, we want to check at least the motor function of 4 cranial nerves that are in the medulla that can give us drastic information to give us on the right course of what our person can't tell us, because the brainstem only responds to input and output. That's the most important thing. Do we have a possible Chiari? Do we need to go in a different direction? Do we need to get this functioning map online? Now we can dance with the sensory dimension. The sensory dimension of cranial nerve number 9, glossopharyngeal, is our most essential function. Oxygen regulation. It works with your baroreceptors and your chemoreceptors. So if I have a dysfunctional swallow, if I have an oral gag, then I know my glossopharyngeal on the sensory dimension is not doing its job, the most essential job. Regulate oxygen. What is the oxygen? We need to measure it. It also measures our second most important dimension. What is our exhaled CO2? Once you measure your exhaled CO2, does it repeatedly stay below 35 millimeters of mercury in the exhalation dimension? If it does stay below 35, we are going to have dysfunctional perception of our entire system. Our pH is changed, and we are not having accurate feedback loops. This is a huge component to chronic pain. If my oxygenation is below 97%, my perception for self-regulation is going to be faulty. We do not want these faulty patterns, but if we don't measure oxygen, if we do not measure exhaled CO2, we are missing dramatically essential elements in my viewpoint to find out the health and wellness and to get our client and patient on the path to healing and recovery. From a sensory dimension, the next function we would do is check the sensory dimension of the facial nerve. That would be on the anterior 2/3 of the tongue. What we would want to do with their eyes closed, we would want to touch the anterior part of the tongue gently, just a touch and go, to find out where do they feel it. You would touch the right side and you would ask the person to go ahead and lift the hand, of course with their eyes closed. Which side did they feel it on? You could touch the left side, you want the left hand, and then you touch in the middle to see if they perceive the middle. If cranial nerve number 7 does not have accurate mapping to the tongue, that is significant input in tongue function to swallow, tongue function to chew, but it also will be mismapped. Now in a sensory dimension on the homunculus, the tongue has a large area of driving sensory input. We do not want this to be inaccurate, because then we're going to have inaccurate function on the other. We're also going to touch the back of the tongue. So again, if we just touch and go and we don't have accurate mapping, then the tongue doesn't have accurate sensory mapping. It also trickles down to change those most important baroreceptors and chemoreceptors. Because when those baroreceptors and chemoreceptors are inadequate, then we don't have a restorative possibility within our human system. The most important nerve that I find mostly mismapped is the trigeminal. So with their eyes closed, I have them bite on a stick so that we keep the jaw neutral, and then I trace each one of the branches. They will sometimes be accurately mapped, but they also have multiple other sensory input. Most of the time, it's connected with an injury. The face was hit the same time the knee was broken. The face was injured the same time the shoulder was done. Or they have the sensory input of surgery. Something was over their face and they received the injury or the surgery dimension to the shoulder. So this mismapping and multiple mapping is what keeps, in my experience, a constant, chronic chasing the pain syndrome. We don't know exactly where it's coming from because we can treat the reported area of injury. We can treat the reported area of pain, but then our treatments aren't fully effective. So once we know that we have multiple mappings, then I go through activating. I go back through the exact thing. I'm going to activate cranial nerve number 1 through smell. I'm going to activate the right side independently because cranial nerve number 1 goes to the right cortex. So if I want a remapping process, if I want to resynchronize the brain, I've got to turn on each independent side. And I can do that through the nose. The lining of the nose is also the sensory branch of the trigeminal, cranial nerve number 5, the second division. When we have that going on, we got to get airflow, we got to get internally more CO2 produced and removed through the nose. Now we bring up our exhaled CO2. We're going to have better accurate feedback on our sensory system from cranial nerve number 9. When that happens, we're going to start the process of healing. Pain perception will go down because what I'm going to be activating is those A and B fibers. We are going to reactivate those myelinated fibers to give accurate signals. Accurate signals decrease the mismapping. Decreasing mismapping decreases the erroneous signals. Everything I'm doing is doing with non-noxious stimulus. Q-tip, a feather, cotton balls. You can do things very gently to wake up the A and B fibers to give good feedback to the brain. We want to override those C fibers that want to talk and give constant signals of pain. So when we increase the CO2 of exhalation, when we increase oxygenation to deliver and retain within our system, we also increase the vagus function, the most important function, to sleep. Once we improve sleep, because our cranial nerves are accurately mapped, accurately functioning, we have decreased pain, increased quality of sleep, and now we have healing. Healing, the first step to slowing down the chronic pain cycle. The dynamic functional cranial nerve assessment tool is going to give you guidance so you can see in a short period of time. 10 minutes may be realistic, 7 minutes for the person who's practiced. We can discover what's going on in that sensory cortex. We can non-noxiously activate cranial nerves. We can integrate them. We can resynchronize them so that our clients can heal. Thank you for this opportunity. My email is loislaney@restoringbreathing.com, and I welcome your questions so we can spread the most wonderful news that recovery is possible at any age through resynchronization of the cranial nerves.